Okay, we're going to continue with NICU Part 6. Let's talk about infants that are at risk for resuscitation. They have a non-reassuring fetal heart pattern, anything affecting blood flow through the placenta, difficult birth, prolonged labor, meconium-stained amniotic fluid, acidosis detected by fetal scalp sample, intrapartum bleeding, unexpected congenital anomalies, oligohydramnios or polyhydramnios, small gestational age, prematurity, multiple birth, narcotic use in labor, infant of diabetic mother, anemia, isoimmunization, fetal maternal hemorrhage, and or parvovirus. So when you talk about infants who need resuscitation, is the baby full term? Is the baby breathing? Is the baby crying? Does the baby have good muscle tone? If you say yes, then that baby probably does not need resuscitation. If one of these is no, then they probably will. Resuscitative efforts are required by 5 to 10% of all newborns to get them to start breathing. So let's talk about the resuscitation steps. Initial steps in stabilization: warmth, positioning, clear airway of secretions, drying, stimulating. Evaluate heart rate and respirations and pulse ox. Oxygen administration. It may begin with 21% and titrate up. A blow-by. Positive pressure ventilation. Endotracheal intubation. Chest compressions. Administrations of epinephrine, volume expanders, or both. So you want to start PPV. That's positive pressure ventilation. If there is apnea or gasping, the heart rate is less than 100, or persistent central and low oxygen saturation despite blow-by of 100%. Bag at a rate of 40 to 60 breaths per minute. Use the pressure gauge so you don't pop a pneumo. If you are bagging, you will need to place an OG tube to vent the stomach. If the heart rate is less than 60 after 30 seconds of PPV, then you begin chest compressions. You really need to get the baby intubated if you're doing chest compressions to coordinate between respirations and compressions. There are two methods for compression: thumbs encircling or two fingers on the chest. If the heart rate remains below 60 despite 45 to 60 seconds of compressions, then push your drugs. You can use the umbilical vein. You can actually push epi down the ET tube. You may need to give bicarb to treat acidosis that occurs from lactic acid buildup. You may need Narcan if you know mom's history. If shock develops, baby needs volume expanders such as normal saline or lactated ringers. Whole blood is needed if there was a fetal hemorrhage or fetal anemia. Packed red cells can also be given for hypovolemic shock. Okay, so we have two images here for positive pressure ventilation and the external cardiac massage and chest compressions. When doing CPR, don't forget to keep the baby warm and dry. Let's talk about respiratory distress syndrome, RDS. Think about another hyaline membrane disease. They had the lack of or inadequate pulmonary surfactant. All preterm infants, as well as SGA, AGA, or LGA, and IDM babies are at risk for this. Each breath is harder than the last one. Signs and symptoms are cyanosis, tachypnea, grunting, nasal flaring, retractions, and apnea. So RDS manifestations include hypoxia. So the PDA stays open, increases hypoxia. They have the impaired response to cold. They revert to anaerobic metabolism. They had the lactate accumulation. They had the impaired cardiac output. They had the decreased perfusion to the vital organs. We run into respiratory acidosis. They have the increased carbon dioxide and decrease in the pH balance. They have metabolic acidosis, which in the increasing lactic acid. They have the base deficit, bicarb drives the pH down. And then x-rays will show a ground glass appearance. So if you look at this image, it's an RDS x-ray image. So let's look at this blood gas evaluation. It shows the pH and it shows the difference between arterial and capillary. And then, of course, we look at the PCO2, the PO2, and the bicarbonate and the base excess. So for RDS treatment, intubate give surfactant, wean off vent, extubate ASAP to bubble CPAP. So let's look at some of the clinical assessments that are associated with respiratory distress. You're going to check skin. So is there pallor, mottling, cyanosis, edema? You're going to check for tachypnea, apnea, retractions, nasal flaring, grunting, harsh breath sounds or rhonchi, cardiac murmur, PMI shift to the left sternal border. Is there hypothermia? Are they hypotonic? Do they have a flaccid tone? Is there any seizure activity? You're going to monitor for all these during your clinical assessment. Okay, so what about transient tachypnea of the newborn, TTN? It usually results from excess fluid in the lungs. Infant breathes normally at birth but develops symptoms of respiratory distress about 4 to 6 hours of age. AGA preterm and near-term infants is usually when it occurs. Clinically resembles RDS. It's prevalent in cesarean birth newborns. It usually improves after 24 hours of age. X-ray usually shows overexpansion of the lungs after 3 hours. So nursing care is going to involve initiating oxygen therapy. You may have to use an oxy hood. Intravenous fluids for fluid and electrolyte requirements, restricting oral feedings until the respiratory status improves, restrict feeds due to aspiration risk, and then risk factors can include late preterm, near-term babies, maternal diabetes, asthma, the male sex, macrosomia, C-section with or without labor, poor uterine perfusion, prolapsed cord, and or breech presentation. Then we have meconium aspiration syndrome. That's a presence of meconium in the amniotic fluid. Fluid is aspirated into the tracheobronchial tree in utero or during the first few breaths taken by the newborn. It can affect any baby who was stressed prior to birth. So let's think about this. Why is poop in the lungs bad? Well, because it causes mechanical obstruction in the airways. Air can get in, but it can't get out because the alveoli become overdistended and causes pneumo. Then we have chemical pneumonitis, it leads to secondary bacterial pneumonia. We have vasoconstricts, the pulmonary blood vessels, PPHN, persistent pulmonary hypertension, and it activates natural surfactant. And then we have biochemical alterations due to it, like hypoperfusion, hypoventilation, extreme hypoxia, metabolic and respiratory acidosis. So let's think of some clinical manifestations. We have fetal hypoxia. It can occur days before minutes before birth. Sudden increase in fetal activity is followed by diminished activity, slowing of the fetal heart rate or weak, irregular heart rate, presence of meconium-stained amniotic fluid. There's distress at birth. That can, include the pallor, the cyanosis, the apnea, the slow heartbeat, the slow apgars, the respiratory depression, the stained nails, and the cord. And then x-rays will show asymmetric, coarse, patchy densities and possible hyperinflation. So, meconium aspiration syndrome, if the baby is not vigorous at birth, immediately intubate and suction out the lungs. If the baby is vigorous, then just observe for complications. The ongoing assessment for signs and symptoms of respiratory distress is what you're going to be monitoring. You'll need to provide supportive care of the infant requiring the mechanical ventilation or the ECMO. Treatments will include or can include the antibiotics, the CPT, the suctioning, and or bicarbonate. This concludes NICU Part VI lesson.